welcome to the deep dive.
Yeah,
You're here for a really focused breakdown on bronchitis.
that's right.
We're using some high-yield revision insights, basically to get you exactly what you need, fast. Think of it like a shortcut, to understanding bronchitis, maybe for exams or just, sharpening your knowledge.
Absolutely. We'll cover the essentials.
Great. From basics to management, keeping it tight and memorable. Okay, let's get into it.
Right. So bronchitis, simply put, it's inflammation. Inflammation of the bronchial tubes, those breathing tubes in your lower respiratory tract.
Okay.
Now, the first big thing to split is acute versus chronic.
Right, the duration.
Exactly. Acute, you're looking at a cough, maybe up to 3 weeks. Chronic, that's a cough that sticks around. 3 months or more for 2 years running.
Got it. 3 weeks versus 3 months plus.
Precisely. And acute bronchitis, it's interesting, much more common when it's colder, autumn, winter. Maybe 80% of cases happen then.
Wow, 80%.
Yeah. But the good news usually is it gets better on its own.
Self-limiting.
Yeah. And it's almost always a virus causing it. Complications like a bacterial infection popping up on top or pneumonia, actually pretty rare.
Okay, so mostly viral for acute. What are the usual culprits we should remember?
Exactly. Think viruses first, often the same ones that give you a cold or the flu.
Oh,
So the big ones are influenza, parainfluenza, rhinovirus, coronavirus, and RSV respiratory syncytial virus.
usual suspects.
Pretty much. Less often you might see bacteria like Bordetella pertussis, that's whooping cough, or Mycoplasma, chlamydia pneumonia.
And irritants. You mentioned those briefly.
Yeah, less common, but exposure to irritants can sometimes trigger it too.
Makes sense. So who's more likely to get acute bronchitis? What are the risk factors?
Good question. For acute, it's mainly about exposure to those viruses we just listed.
Okay.
Also, if your immune system isn't quite up to scratch, you're more vulnerable.
Right.
And then environmental stuff, smoking, air pollution, they can irritate things and up the risk.
And for chronic, is it similar?
For chronic, the big one, far and away, is long-term smoking.
Right. That makes sense.
But also, think about people exposed to dusts or chemicals at work, ongoing air pollution, lots of chest infections in the past, and again, a weaker immune system. It's that long-term irritation.
So on a basic level, pathologically, what's happening inside the airways? Acute versus chronic.
Okay, so acute bronchitis. The bronchial tubes get inflamed, swollen, red, and they produce more mucus.
Hence the cough.
Exactly. That inflammation, the extra mucus, that's what makes you cough. Now, chronic, that's long-term irritation, long-term inflammation.
So more constant.
Yeah, you get excessive mucus production, that persistent cough. But also, over time, the actual structure of the airway lining can change.
I see. Okay, so if someone comes in coughing, bronchitis is on the list, but what else could it be? The differential diagnosis?
Right. Important for exams, pneumonia is a big one you need to rule out.
Definitely.
Also, if it's a long-term cougher, could it be their chronic bronchitis flaring up? Or an asthma exacerbation? They can present with cough and wheeze, too.
Anything else?
Even things like allergic rhinitis, with postnasal drip causing a cough. You have to look at the whole picture.
And just how common is bronchitis?
Acute bronchitis is super common. All ages get it. Most people probably have had it.
Right.
Chronic bronchitis, that's often tied up with COPD, tends to be more in adults over 40, especially smokers or those with that long-term lung irritation.
So what are the classic signs and symptoms you'd look for?
Okay, for acute bronchitis, the main thing is that cough. Can last several weeks. Often brings up sputum clear, maybe colored, maybe some chest discomfort, a bit of a fever, maybe slightly breathless.
And chronic, just to recap.
Chronic is defined by symptoms, mainly that cough, for at least 3 months a year, 2 years straight.
Got it.
Acute usually starts like a cold, cough, maybe productive, maybe not, sore throat, runny nose, rhinorrhea, sometimes a wheeze.
And on examination, what would you expect to find?
Chest exam in acute bronchitis is usually, normal, but you might hear a wheeze.
Okay, that's key. So how do you tell it apart from pneumonia clinically? Any specific clues?
Yeah, really important distinction. With pneumonia, you're more likely to see significant sputum, wheezing, and definite breathlessness. These might be less obvious or even absent in simple acute bronchitis.
And examination findings?
On exam, for acute bronchitis, you typically don't find those focal signs like dullness when you tap the chest or crackles crepitations, maybe just a wheeze.
Right.
Also, feeling really unwell, systemically bad muscle aches, high fever, that's more common with pneumonia. Less so with typical acute bronchitis.
So when do you actually need to run tests?
Generally, for straightforward acute bronchitis, you don't need tests. It's a clinical diagnosis. History and exam usually do it.
But sometimes you do.
Yes, if symptoms are really bad or going on for ages, or you suspect a complication like pneumonia.
Then what? Chest x-ray.
Exactly. Chest x-ray if you're worried about pneumonia. Microbiology like sputum tests or swabs, not routine. Maybe if you suspect flu or pertussis, especially in someone high risk or in hospital.
Any other tests?
Procalcitonin can sometimes help tell bacterial from viral, but again, not standard. CRP testing might guide antibiotic decisions in some places, but it's not really for diagnosing bronchitis itself. Remember, diagnosis is typically clinical.
Okay, so diagnosis is usually clinical. How do you manage acute bronchitis then?
Management is mainly about feeling better, symptomatic relief.
So rest, fluids.
Yep, rest, lots of fluids, maybe some over-the-counter meds. Crucially, antibiotics are usually not the answer for acute viral bronchitis.
Right, that's a key take-home.
Definitely. Chronic bronchitis management is different. Stopping smoking is huge. Maybe inhalers, rehab, managing COPD if it's there.
So for acute, what can you suggest over the counter?
Things like cough syrups or lozenges might help soothe the cough. And SAIs, like ibuprofen, can be good for aches and pains, especially if it feels like flu.
You said antibiotics are usually not needed. When might they be considered?
Okay, specific situations only. If you strongly suspect whooping cough, Bordetella pertussis, then yes, macrolides are used, especially if the cough is less than 3 weeks old or maybe up to 6 weeks in pregnancy.
And flu?
If it's confirmed flu and the person is hospitalized or high risk, antivirals like oseltamivir might be used, but that's specific circumstances.
What about non-drug measures? Things people can do themselves.
Yeah, definitely.
Yeah.
Focus on symptom control. Throat lozenges, honey can soothe the cough. Good fluid intake is always good advice.
And smoking.
Absolutely. If they smoke, really encourage quitting. And simple painkillers for discomfort.
You mentioned CRP guiding antibiotics sometimes.
In some guidelines, yes. If someone is systemically very unwell or has serious underlying conditions or maybe a very high CRP level, a doctor might consider antibiotics. Doxycycline is often first line, but not in kids or pregnancy. Amoxicillin could be an alternative, but again, this isn't for your typical case.
Okay, what's the usual outcome? The prognosis for acute bronchitis?
Generally, really good. Most people get completely better in a few weeks with just supportive care. No lasting problems usually.
And chronic.
A chronic bronchitis, especially if it's part of COPD, can be more serious, potentially progressive. But getting diagnosed early, managing it well, quitting smoking, that can make a huge difference to outcomes and quality of life.
Are there any complications we should be aware of?
Well, with acute, the main risk is a secondary bacterial infection turning into pneumonia. Less common, but possible. Sometimes the airways can stay a bit twitchy for a while, bronchial hyperreactivity, and it can flare up underlying things like asthma.
And long-term for chronic?
Long-term, chronic bronchitis is a major risk factor for developing COPD.
Okay, great. So let's quickly summarize the really high-yield points for everyone listening.
Sounds good.
Key thing, know the difference between acute, usually viral, short-lived, self-limiting, and chronic longer-term, often linked to smoking.
Right. And for acute, management is about symptoms. Rest, fluids, maybe OTC meds.
And crucially, antibiotics are generally not needed. Only consider them for specific things like suspected pertussis or maybe confirmed flu in high-risk folks.
Exactly. Keep it simple for most cases.
Perfect. That distinction and the antibiotic stewardship point are really key, especially for exams like the MSRA.
Absolutely. And for anyone prepping for the MSRA, remember resources like passthemsra.com and freemsra.com are out there to help you consolidate this kind of knowledge.
Great resources. Thanks for that excellent breakdown.
My pleasure.